Good morning, good afternoon, good evening. We are now in the last part. You can tell I'm excited to end this because we're in the last part. Now we're on the surgical therapy. Last video we discussed medications. Now we're gonna discuss the more permanent uh, interventions for PD. So I'm not actually gonna explain a lot. This is actually really short. This might be just less than 5 minutes. These are the three main ones. We have deep brain stimulation. So deep brain stimulation, as the term suggests, it just provides it's like similar to electrotherapy, but for your brain. So according to research and clinical findings, it has had effects on averting later problem of dyskinesia and motor fluctuations, and especially with levodopa-induced dyskinesias, because if you remember correctly from last video, I said that levodopa can cause dyskinesia, which is involuntary movement. So if you combine levodopa with deep brain stimulation, this could help the patient reduce the side effects of the medication. Next, we have a more permanent surgical option, which is fetal nigral transplantation. So this just replaces the generated dopamine neurons by implanting embryonic dopaminergic cells. So it's just a transplant, sort of. So you could consider that this could be considered for like a more permanent option. Same with globus pallidus internal pallidotomy. So this just resects part of the GP, and it usually improves contralateral dyskinesia. Actually, that's it for surgical options. Um, yeah, that's it for this lecture. It's been a long, long ride. I guess if you were to ask me what would be the most crucial parts in this lecture, would probably be the clinical manifestations. It's hella important to know what are the benchmarks for Parkinson's, because this would also help you formulate the diagnostic criteria, especially these three main. Because once you know this, if you're given like a case on an exam that this patient comes into the hospital and then complains of da 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 da, you would immediately know, or not really immediately know, you would know what tests to do, and you would determine, you could pinpoint um what the affectation truly is. Because it could be a trick question. It could be essential tremor. So you have to watch out. Is the tremor that the patient has resting or kinetic? If it's kinetic, it's essential. It could also have like, is the patient experiencing chorea? Because chorea is not a hallmark of Parkinson's. It's for Huntington's. Or is there, let's say the patient presents with uh sustained contractions like dystonia, but you know that dystonia is one of the symptoms of Parkinson's. But then again, what about Wilson's disease? Wilson's disease can also have dystonia with the wing bird tremor, you know? So these are just some things. Um, and then I guess another important one is definitely the the medication. So levodopa, you don't really need to memorize the dosage, but you need to know how it works and what is its truly effect to improving symptoms of Parkinson's, especially how the inhibitors help. So this is basically it for Parkinson's. I like this picture. Okay, sorry. I hope you did learn something from this lecture, because I don't know, maybe you didn't learn anything. It's also fine if you didn't learn anything. This is mostly just for my personal use. But oh, my reference is Merritt's Book of Neurology, so that's where I base all of the information here. You could check that out if you want text format. But essentially, what I wrote here are the ones that what was written there is the ones I put there. So thank you, and good luck for whatever why you're watching this video. Leon Kennedy. Bye.